Good afternoon, everybody. Thank you very much, the organizers, for inviting us to share our data this afternoon. I'm going to share with you an integrated HIV geriatric clinic model, which we have implemented recently. So everyone in this room is aware that the population of older people living with HIV is increasing globally. But that rate of increase is predicted to be highest in sub-Saharan Africa, which has the highest burden of HIV. The number of people living with HIV over the age of 50 is predicted to be 10 million in sub-Saharan Africa by 2040. It's evident that aging with HIV is associated with a higher prevalence of multimorbidity and increased risk of non-communicable diseases and geriatric syndromes. And there have been several models of integrated geriatric and HIV care described, but very few from the sub-Saharan Africa region. So just to give you a little bit of an idea of where we come from, Newlands Clinic is situated in the suburbs of Harare in Zimbabwe. We are a Swiss-funded, non-governmental organization funded by the Rudy Luti Foundation, and we offer comprehensive, free HIV outpatient care to nearly 8,000 people living with HIV. We work very closely in collaboration with the Ministry of Health. We have a very strong private-public partnership, and the clinic is primarily a nurse-led clinic with doctor supervision. So in 2023, as of this year, we have a cohort which over a third of patients in our cohort are over the age of 50, and this has been a significant increase since 2013, when that figure was 15%. So, to adapt to the changing epidemic that we see every day in our clinic, we decided that we needed to introduce a service that would cater to the needs of our aging population. Our goals of the clinic was to establish a differentiated care model for older people, which incorporated both the management of medical conditions with the assessment of geriatric and syndromes. We wanted to introduce a service which was multidisciplinary, integrated, and person-centered. And we aimed to develop personalized care plans with the focus on optimization of intrinsic capacity and functional ability. So, to go about designing the clinic, we based it largely on the 2017 WHO Integrated Care for Older People guidelines. The comprehensive geriatric assessment that we use focuses on domains which include physical health, mental health and cognition, intrinsic capability, and socioeconomic issues. The screening tools we selected were based on any tools that had regional validation, or if that was not possible, tools that was recommended by local guidelines, and or whether it was feasible to use that tool in our setting. So this is a slide which summarizes all the different screening tools and assessments that we do over the various domains. For the purposes of time, I'm not going to go through each tool, but I will speak to some of them as I present the results a little later on. So in October 2022, we invited all of the Newlands Clinic patients who are aged 85 or older to attend an integrated visit. The visit consists of two main components. So a nurse interview initially, which is 60 minutes long, which includes a history and examination, and is implemented with one of our two trained geriatric nurses. This is then followed by a doctor review in which the personalized care plan is formulated, and the doctor also completes some other assessments shown here. So in order to standardize care, the CGA is conducted with an electronic wizard, which is part of our electronic database, and we've embedded all of the different assessment and screening tools that we used within that wizard, and a geriatric blood panel is drawn for all of our patients. So I'm going to share with you the results of the first 100 patients that we've seen in our clinic since October 2022. The majority of our patients are female, 69%. This reflects the demographics of our whole clinic in terms of gender. The median age of the patients is 69, and our oldest patients that we've reviewed is 91 years old. The body mass index, the mean body mass index is 26 and slightly higher for females than men. And this is a cohort of patients that have had extensive exposure to HIV with a median time since diagnosis of 16 years and a median duration on ART of 15 years. Most of the patients that we've seen were significantly immunosuppressed on entry into care. Their median baseline CD4 count was 162, but the current CD4 count median was 481. And what you can see here, which was maybe not surprising to us, is that the virological suppression rates in this cohort are extremely high. All of the patients had viral loads of less than 1,000 copies, and 94% had viral loads of less than 20. So there was a very high prevalence of comorbid conditions. 80% of our patients were known to be hypertensive, 20% known to be diabetic, and 43% of our patients living with chronic kidney disease. Of the hypertensive patients, 73% of them had good control, as defined just by one blood pressure of 140/90, the most recent. Diabetic control was also good, with 80% of patients having HbA1c of less than 8%. The median comorbidities was 3 in the cohort, and the median number of co-medications was 4. So following the visit, 86% of the patients that we see received at least one new additional diagnosis or intervention, and 35% of them received an external referral. So this slide shows all of the additional diagnoses, the prevalence of the diagnoses that we made in the 100 patients that we've seen to date. So using the short physical performance battery, 50% of patients were assessed as being pre-frail and 9% as frail. Nearly half of our patients had impaired mobility using the 3-meter walk test, which was part of our SBPPB. 9% of our patients reported recurrent falls in the previous 12 months. We used a mini nutritional assessment and recorded that one patient was assessed as being malnourished, but 28% of patients were found to be at risk. We found an extremely high percentage of vitamin B12 deficiency, which was quite surprising to us, but we suspect that this is actually nutritional deficiency. 55% of our patients required vitamin B12 replacement. Using the FRAC score, and in a few cases DEXA scanning, we diagnosed osteoporosis in 18% of our patients, and bisphosphonates were prescribed as appropriate. We crudely measured cognitive impairment using an abbreviated mini-mental score, and 21% of patients had a score that was less than 8 out of 10. Nearly a quarter of our patients had depression and/or anxiety, and these patients we referred to an on-site mental health department. We have a clinical psychologist and 3 counselors. Cardiovascular risk assessment was done using the Framingham risk score, which is recommended by the South African Heart Association, and 43% of our patients had risk scores of above 15%, requiring initiation of statins. Sexual dysfunction was reported by 10 out of 30 men. None of the female patients reported any sexual dysfunction. Visual and hearing impairment was recorded in nearly a third of our patients. And as a result of this integrated visit, 4 patients had a new cancer diagnosis. So 4 men were diagnosed with prostate cancer and 1 woman with vaginal cancer. So in summary, we reported a high prevalence of comorbidity and age-related syndromes in this cohort of older people living in Zimbabwe. The majority of the patients received additional diagnoses or interventions as a result of the integrated care, which was targeting age-related domains. And this is despite long-term care. So this is a group of patients that have been coming to Newlands Clinic every 3 months for at least, for most of them, for at least 10 years. So we believe that the high burden of multimorbidity that we've reported highlights the need for differentiated care in older people, which goes beyond dispensing antiretroviral therapy and encourages the comprehensive assessment of geriatric domains. We recognize that our model is limited in terms of reproducibility in the resource-limited public health clinics in Zimbabwe, but I think the data really just emphasizes the great need to reconceptualize HIV care for older people in resource-limited countries. And this is really essential to improve health outcomes in older people living with HIV. So I'd just like to say thank you. I'm going to leave you with a bit of feedback from our patients, which has so far been pretty positive. I want to thank all the Newlands Clinic staff, of course, all of the patients, and the IHGC team. Thank you.